Good afternoon, ladies and gentlemen. It's periphery to the Fore peer learning. It's a stage for the physicians in the periphery to sort of come to Colombo, the main centers, and impart the knowledge that they have got during their uh, experience outside Colombo and during their foreign training, and make an impact on the people who are in the learning process. So it's a very popular program among the registrars and the physicians and the senior physicians, especially because they have forgotten most of the stuff. Today, we have two lectures. The first lecture is by Dr. U.D.N. Prasad, who's currently serving as an acting consultant physician at District General Hospital, Monaragala. He obtained his MBBS in 2010 and received his MD in medicine from the University of Colombo in 2019. He also has completed a certificate course in postgraduate research. Dr. Prasad has received his overseas training in Flinders Medical Centre, Adelaide, South Australia, as a medical registrar. The topic that he has chosen for today is Rising from the Depths, Mysteries Unravelled. Over to you, Prasad.
Good afternoon, everybody. Thank you very much, sir, and thank you to CCP for giving me this opportunity. Rising from depth, mysteries unrevealed. This name was suggested because this is something which regarding medicine in diving, and actually the patient, based on a case, the patient was presented to me at DGH Hambantota. So the patient was a diver, diving, doing by people to various purposes, recreational are the commonest, but in Hambantota they are doing this as a fishing, for the fishing purposes, other than that military purposes like also currently happening. So I will start from the case first. So Mr. N, he was a 53-year-old, previously healthy person. He was a scuba diver. I will discuss more about scuba diving in a few moments. Later. So he's dived to a level of 90 feet in the sea in the morning and remained there for 30 minutes and ascended to the air level within a few minutes. So a few hours later, the patient developed following symptoms. He was breathlessness and abdominal pain, diarrhea, and oliguria. He presented to our review. So on examination at very first, he was conscious and rational, but he was dyspneic. Respiratory rate was around 40, saturation slightly lower, 92% on Romeo. Pulse rate was not that high at the beginning, 60. Blood pressure 120/80, and lungs was clear. But most important thing is there was generalized abdominal tenderness in the patient's abdomen. So our main differential diagnosis was this may be the pneumothorax or pulmonary embolism or acute coronary syndrome or some diving-related emergency initially. So we performed ABG. It was showing mild acidosis, mild hypercarbia, maybe due to hyperventilation, as is dyspneic, mild hypoxia, and some raised level of lactic acid and reduced bicarb levels, mild acidosis. So this is the urgent full blood count. Somewhat important points here. The WBC count is high. You can see 29,000. He didn't have any fever during last days. So other than that, HB is unexplainedly high, 20, and HCG 261. So platelets slight marginally low. So it shows some hemo concentration. So suggestive of dengue, but clinical history not indicating. So over an hour, patients rapidly deteriorated. GCS reduced, saturation was dropped to 82, even though we have taken action for this, while on oxygen, pulse rate was 112 and blood pressure dropped while on iron drops. So ECG only showed sinus tachycardia, so somewhat unsuggestive of acute coronary event. And chest X-ray, there was no pneumothorax or pneumopericardium. So our pneumothorax TD also excluded. Repeat ABG, there was something unexpected thing happened because you can see how fast his pH dropped. See, 7 point, these are based on ideal values of the patient, 7.3 to 6.5, and carbon dioxide increased from 33 to 87, and the oxygen partial pressure reduced from 90 to 70, and you can see lactic acid level markedly high, and bicarb also dramatically reduced. So pulmonary embolism somewhat unlikely with this context. So because of the abdominal severe pain and the tenderness, we performed urgent ultrasound abdomen by our radiologist, and he found some abnormal echo texture in the ultrasound scan, and he suggested to do urgent CT abdomen. So I'm happy to show you this abdominal CT. Sure. No, it's working, sir. So you can see the liver, there's tree-like expansion, especially in the biliary tracts in the CT. So that was the finding, and it was diagnostic based on the history. Hope you have seen. So CT was reported as extensive pneumobilia, along with 4 kinds of gases in the abdominal, pelvic, venous system, and main pulmonary trunk, left brachiocephalic vein, indicative of severe decompression syndrome. So we diagnosed this patient as severe decompression syndrome. So I would like to discuss some details about this scuba diving and decompression syndrome and diving associated emergencies. So scuba denotes self-contained underwater breathing apparatus. It's a mode of underwater diving whereby divers use breathing equipment that is completely independent on the surface breathing. So therefore, even though it's limited time, there's variable endurance with this scuba method. It's very popular among divers. So coined by Christian J. Lambert in 1942, and usually they are using compressed air, but various combination of gases also there are, oxygen with nitrogen, oxygen with helium, all 3 combinations like that. So greater independence and movement than surface supply divers. So you can see 2 types of scuba methods. One is open circuit method, and the other one is rebreather type. The difference between open and rebreather, open circuit during that method, from the mouthpiece, the diver will release oxygen air to the water, direct to that water. So in the rebreather pattern, they will exhale direct to the mouthpiece. So air will recirculate, and the oxygen in the exhaled air will be reused. That's the difference. So this is the form of open circuit method, and this is the rebreather type scuba. So diving is a safe activity. Difficult to estimate the number of divers in Sri Lanka, but there's an average fatality rate of 1.8 per 100,000 divers. This is in USA. And variety of diving related injuries and illnesses can occur. So main 4 injuries that can happen is barotrauma are the commonest. From that, most catastrophic barotrauma is arterial gas embolism and decompression sickness. Second one, this is what happened to our patient, and nitrogen narcosis and immersion pulmonary edema. Those are the main 4. So before going to the discussion about the decompression sickness, I would like to tell about these 2 laws in gas behavior. One is Boyle's law and other is Henry's law. Boyle's law means at a constant temperature, the volume of gas varies inversely with the ambient pressure. I will explain it in few more minutes. And Henry's law, at a constant pressure, the amount of gas that is dissolved in the liquid directly proportional to the partial pressure of that gas. So we will discuss this in further. So this is simply like this. When you take a carbonated drink or carbonated water bottle, once the lid is closed, you can't see any bubble. But when you open the lid, that pressure will be released and the bubbles will appear. So this is the Henry's law actually. So this is not happening even at our patient's liver or and venous system. So I would like to explain much somewhat detail. So you can see this diagram in this left side. Nice, the sun has risen and clouds are there. So 1 liter in this air level, that means at sea level, how will change? We'll see. So from 1 by 1 square, the depth under the water will indicate. So from 10 meters and from 20, 30 meters. So at sea level, at the ambient air, we are usually taking the pressure as 1 atmosphere. 10-meter depth, we're taking as 2 atmosphere, 23 atmosphere, and 34 atmosphere. So you can see, according to the Boyle's law, the volume of the gas reducing. 1 liter has become 0.25 liter in 30 meters, 100 feet. That's the depth of a patient dived. So in the atmosphere, I would like to discuss about the partial pressures. In our normal air, 78% are nitrogen, 22% are oxygen, and 0.05% are carbon dioxide. But in the lungs, it is somewhat different. You can see only 75% of nitrogen, 13.5% are oxygen, and the partial pressures also mentioned here, and 5.3% are carbon dioxide. This is because unlike atmosphere, at our lungs, capillary alveolar level, oxygen is utilized and traveling to the tissues by the blood. So oxygen partial pressure somewhat, the percentage is somewhat low. Carbon dioxide is produced by the metabolism from our tissues. So the percentage of carbon dioxide is high compared to the atmosphere at lungs alveolar level. So according to that Henry's law, you can see the partial pressures of nitrogen and the nitrogen in the blood and the alveoli, there's no difference. So there is no any exchange of nitrogen at air level in our lungs at the sea level. So but in contrast, oxygen, you can see the oxygen partial pressure 104 at alveolar level, but in the blood it is 40. So there is steep. So oxygen will dissolve to the blood. So carbon dioxide on the opposite, the partial pressure is high in the blood, and carbon dioxide will move from blood to the capillaries. That's what need to happen. So you can see this is the other picture on the corner that implies at the 30 meters, 100 feet or 4 atmospheres. So you can see the nitrogen pressure has increased by 4-fold. In the nitrogen at the lung, it is 570, but in the lungs at 40 meters under the water, 30 meters under the water, it is 2,500 millimeter mercury. But the blood partial pressure of nitrogen at blood remains same. Other than that, you can see the oxygen 104 at lungs in the sea level, but at under the water, 30 meters under the water, oxygen pressure has increased to 450, 4-fold. So you can see both nitrogen and oxygen dissolve more and more in the blood in underwater. So this is according to the Henry's law. So these basics it's easy to discuss about the decompression sickness as diver descends and breathe gas under increased pressure, tissues become saturated with dissolved nitrogen as predicted. So as the diver returns to the surface, some of gas tensions in the tissue may exceed the ambient pressure, lead to liberation of gas from the tissues in the form of bubbles. So the location of the bubble formation depends somewhat upon the tissue characteristics. So decompression sickness and decompression illness is somewhat different. Decompression illness means both this decompression sickness and arterial gas embolism. Even though the bubble formation and the treatment are same, the mechanism and pathophysiology different in these two. Decompression sickness, the pathophysiologic condition that occurs when bubbles form in the tissues due to supersaturation. By the way, the arterial gas embolism is pulmonary overinflation and causing barotrauma. Then air will move from alveoli directly to the circulation at the lung level. That even can happen in the ventilation of a patient. Other than that, in the arterial gas embolism, gases tend to stay in the arterial circulation, but decompression usually at venous and lymphatic systems. So the liberated gas bubbles damage organ function by blocking the blood vessels or rupturing and compressing the tissue, and endothelial damage and activating clotting and inflammatory cascade. That is what happened in our patient's full blood count. You have seen endothelial damage has happened and plasma has leaked. That's why hemoconcentration happened. So that is a mechanism of this decompression sickness symptoms and the damage, organ damage. So what the risk factors are to getting this decompression sickness worse are right to left shunt, patent for Monaragala, AST, VSD, PDA, or tetralogical fallot, anything, but the shift should be from right to left, then venous circulation gas will move to the arterial circulation. Air travel, this is important point. Air travel, if you have dived in the deep sea, you should wait 12 hours if it's a single dive, and multiple dive, 48 hours should be patient has to the person has to wait, because the decompression will happen more easily with the altitude. Others are obesity, age, sex, also these factors. Symptoms and signs. I would like to say the volume and the location of these bubbles will decide. Gas bubbles generally present in the venous circulation because the low pressure in the venous circulation compared to the arterial circulation. Presence of bubbles alone does not necessarily mean that patient will develop decompression sickness. So these are the brief sketch of symptoms and signs. Most commonest are musculoskeletal symptoms, shoulder ache, joint arthralgias, basically boring type ache. So cutaneous are also common, mostly patchy paresthesias, and rashes also there. Spinal cord, I'd like to say the paraplegia, even quadriplegia, like symptoms can happen in this decompression. Urinary retention due to bladder sphincter dystonia. Inner ear symptoms like nausea, nystagmus, brain. Compared to arterial circulation, mild executive dysfunction like concentration and memory symptoms will present. Cardiopulmonary, as in our patient, dyspnea, cough, chest, chokes, like symptoms, and cardiovascular hemoconcentration, shock. That is what happened to our patient. So other symptoms, so on. So this is the cutis marmorata, one of cutaneous symptom, not characteristic, but can happen. Livedo erythematosa. So compared to livedo reticularis, you can see the expected difference. So how we diagnose? Diagnosis basically clinically by history and physical examination. Other investigations also we can take as a, evidence. So management of the decompression sickness, that is the important thing. So decompression and acute arterial gas embolism, both are same management. Pre-hospital, we have to give normobaric oxygen until hyperbaric oxygen available, and keep the patient in horizontal position, avoid hypothermia, and we have to hydrate the patient as patient becoming dehydrated. So isotonic or crystalloid fluid should be started, and we have to transfer the patient rapidly to the place where hyperbaric treatment is available. And in the emergency, evaluate the extent and the need of hyperbaric oxygen therapy. So after stabilizing airway breathing circulation, until hyperbaric oxygen available, normobaric 100% oxygen we have to give. The other important thing before giving hyperbaric oxygen therapy, if there are pneumothorax, you have to decompress that. Otherwise, it's an absolute contraindication for hyperbaric oxygen. In the meantime, DVT prophylaxis may be necessary. So I would like to tell a few details about the hyperbaric oxygen therapy. These pictures showing the monoplace and the multiplace therapy modes. So this is the primary or adjuvant therapy for multiple medical conditions. So these are the role of hyperbaric oxygen, even though we are talking about air and gas embolism, carbon monoxide poisoning, hydrogen peroxide poisoning, clostridial myonecrosis, traumatic ischemia, crush injuries, traumatic ischemias, and problematic diabetic wounds also will benefit from this. Severe anemia, actinomycotic brain abscesses, refractory osteomyelitis, radiation tissue necrosis. So how this happens, we'll discuss in a few moments. So this is the mechanism of action in hyperbaric oxygen is increased delivery of oxygen. So this is according to Henry's law, as I described earlier. Once we increase the atmospheric pressure or the surrounding pressure, the oxygen carrying capacity of the blood will increase. At sea level, at 1 atm, 0.3 ml of oxygen only will carry. But compared to that, at 3 atm level, 6 ml of oxygen will carry into the tissue by our blood. So that's one mechanism of action. Apart from that, reduction of gas bubble size according to Boyle's law. So this is very important, especially in our patient like decompression sickness. Once we do the decompression, that gas bubbles will disappear, again dissolve in the blood. So that is another mechanism. Especially in carbon monoxide poisoning like conditions, the antagonism of the carbon monoxide carboxyhemoglobin, the oxyhemoglobin dissociation curve will move, and carboxyhemoglobin's half-life will reduce. There's another mechanism of action. And wound healing, the mechanism is due to reactive oxygen and nitrogen free radicals and some other fibroblast proliferation and angiogenesis like things. So hyperbaric oxygen therapy is administered with pressurized oxygen or air. Chamber pressure usually between 2.5 to 3 atm. Treatment times varies 45 minutes to 30 minutes depending on the indication. The hyperbaric oxygen therapy, there are specialized physicians for deliver these specialized persons to do this. So they will decide whether to give acute therapy or chronic therapy. Acute means 1 or 2 sessions, chronic means up to 30 sessions depending on the indication. Prolonged therapy also can cause oxygen toxic. That is the side effect, one of side effect. So contraindications are only one contraindications, absolute contraindication, that is untreated pneumothorax. Most of the others are relative, somewhat something obstructive airway disease, asymptomatic pulmonary bullae, upper respiratory tract or sinus infections, ear or thoracic surgery, uncontrolled fever, claustrophobia. So complications. Mostly the barotrauma is the complication, and as I said, oxygen toxicity. So sinus barotrauma, reversible myopia, pulmonary barotrauma, seizures, that is not possible to oxygen toxicity. So apart from this, other main indications we discussed, the future directions are there for the hyperbaric oxygen therapy, like treating for acute coronary syndrome, SIRS and traumatic brain and spinal cord injury, sickle cell crisis, fibromyalgia, and acute stroke. I'd like to talk, if time permits, regarding a few more about oxygen toxicity. So, even though it's beneficial to us, there's a harmful effects in the oxygen. So, severe cases can result in cell damage, and which is often seen in central nervous system, lungs, and eyes. So, these are the symptoms: disorientation, breathing problems, regional problems, seizures. So, as I discussed early, apart from the decompression sickness, there are several other diving-related emergencies. One is barotrauma, and other one. Under the barotrauma, pulmonary barotrauma are the commonest, like arterial gas embolism, ear barotrauma, sinus barotrauma, dental barotrauma. So, as I mentioned, pulmonary barotrauma, these are the main types of trauma: arterial gas embolism, barotrauma of the descent and ascent, pneumomediastinum, again, pneumothorax. So this is another type of diving-related emergency, nitrogen narcosis. Any gas can cause narcosis except helium. So, the partial caused by raised partial pressure of nitrogen in the CNS tissues, depth should be more than 30 meters. So what's happening is reversible alteration in the consciousness and neuromuscular function and behavior, somewhat similar to the alcohol and benzodiazepine, but recover rapidly upon return to the shallow depths. So this can lead to drowning, omission of decompression. To prevent decompression, what we have to do is, when you are diving, you have to come in a gradual way. I'm not an expert about that, but slowly you have to come. You can't come within minutes to the surface. So omission of this decompression can happen in nitrogen narcosis. Immersion pulmonary edema is another form of diving-related emergency. This is also recognized diving-related emergency during past 2 decades. So it's a non-cardiogenic form of pulmonary edema, and mechanism is different from the cardiogenic because of the redistribution of the fluids from the legs and abdomen to the lungs. That will happen common among young people and athletes, and treatment similar to the other form of pulmonary edema. So I would like to tell the difficulties that we face when managing this patient here. One thing is the hyperbaric oxygen therapy availability. Only we found at Trincomalee Naval Hospital, only one chamber that also. So the transfer within as soon as possible was a problem in our patient. So the other problem is we can't put intubated patients into the hyperbaric oxygen chambers. So that is another difficulty that we face during management. So the learning point I would like to highlight. So depending on the history, once a patient presented with these sort of symptoms, you have to identify the condition as soon as possible and transfer for HBO when indicated. Thank you.
Thank you, Dr. Prasad. And we can take a couple of questions.
What happened to the patient? Actually, patient's account, because transfer will take around 6 hours, and we can't put the intubated patients, so patient's account.
Actually, the patient cannot be moved by air also, isn't it?
Yeah.
Because it will worsen the
condition.
The pressures inside. Yes. So they were about to put another barotrauma chamber in Monaragala Defense Academy, and the country decided that they can't afford another chamber because of economic difficulties. Say it's good to have something, but whether we can afford another chamber given the numbers that we see at the time.
Yeah.
And it's a wonderful presentation. We heard something that we don't usually listen to. And because you might see these patients at some time, and it opened our eyes into problem that we usually don't see. Any other questions? Any observations?
Yeah, that's the number of divers and the percentage of dive-related emergency is not calculated here. So I told you 1.8% annually in 100,000 divers in United States of America, not here. So yeah.
So the tourism picking up and
Hospital, what is that?
Clinical is a neighbor. Sorry?
There's a, you know, negative.
Yeah.
How many were treated with the paranormal?
Actually, there's Dr. Ravi Deva is looking in charge of that unit, so I'm not aware of that, but maybe they are military for the military training. I think they are using this. So actually, I don't have an idea about how many patients usually treated like this.
Yeah, the Kiranti's point that we are the tourism is picking up, and if we see people dying of decompression sickness, we might have to rethink of our strategy. But whether we should have the decompression chamber in KDU or somewhere where the diving occurs, somewhere in the southern province, rather than in Colombo. I don't think hardly anybody dives in Colombo. Probably. Okay. And any other observations? Thank you again, Dr. Prasad. It was a wonderful presentation.